So is it the best option, Ortho-K or soft multifocal based on my patient? So again, he has almost 6 diopters of myopia, diopter cyst. He has an ECL posture near. He denies allergies. He's not an athlete. And you see there, that is his pupil size. So let's talk about what is considered a good candidate for Ortho-K. And I mean Ortho-K for myopia control, which is a little different than the candidate for Ortho-K for its traditional use of temporary reduction of myopia. And ideal candidates are those who have patients that have large pupils, and I'll get to that in a second. Athletes, as many of you probably know, and then children who are unable to wear soft contact lenses due to allergies. And I'm going to this because it's a question I get often where, ECPs and students aren't sure, which option that they should go with. So let's talk about the pupil size. So here we're going to imagine that this is the Ortho-K lens, and here is the treatment zone, and then here is the area of peripheral myopic defocus. So if we have a large pupil, right, the peripheral myopic defocus will lie in the pupil, and therefore that patient will get the peripheral myopic defocus, which is what's slowing the progression of myopia. However, if we have a small pupil, now that area of peripheral myopic defocus is outside of the pupil, and therefore that patient is not getting that peripheral myopic defocus. That is what is slowing the progression of myopia. So if you look at this patient here, you see here, this is the area of peripheral myopic defocus. Is not going through the pupil at all. And as such, you wouldn't get as an effective outcome if this patient had a larger pupil. So if we think about the average treatment zone size for OK, it's around 3.5 millimeters, 4 millimeters. And then that outside zone of peripheral myopic defocus is 1.5 to 2 millimeters. Ideally, you'll want a pupil size to be around 5 millimeters. Again, this above pupil is too small. So that's why when you're selecting your candidates for Ortho-K for myopia control, not for the traditional means, you want to look at that pupil size and maybe being 5 millimeters or bigger. With children, the issue with large pupils in general, most people know that can cause some halos and decreasing, contrast sensitivity, but most times children can adapt to that. In my experience, the children that I've treated haven't had issues with this, okay? Now, looking at it in another way, and there's been a lot of discussions on this as far as the optic zone size. So optic zone size may matter as far as, the efficacy of the myopia control, meaning if I have a smaller optic zone size, there is a smaller treatment zone, and then more of this peripheral myopic defocus will get through the visual axis, and therefore will have a better treatment. There was a study that did take a look at this. The smaller optic zone size, with the 5 millimeter optic zone size, there was a greater reduction in axial elongation there. For both sizes, there was the same contrast. There was same reduction in same visual performance. However, with that smaller size or optic zone size, there was a decrease in contrast sensitivity. So I think that is to be expected. However, keep in mind, as I said before, the children more adapt to that than an adult who's like driving and things like that. So I think more studies are needed. However, it appears that 5 millimeter optic zone may be advantageous. The other thing you want to look at is, of course, if a child is an athlete, I think Ortho-K is a great option. The greatest benefit of Ortho-K lenses is the freedom from glasses, the freedom from contact lenses during the day. And so with athletes, especially swimmers, we're not worried about the risk of wearing contact lenses while they're swimming and the complications associated with that. And just in general, for any athlete, not worrying about wearing contact lenses or spectacles while doing a sport. But let's talk about refractive error. We are so fortunate today to have Ortho-K options that can treat pretty high refractive errors. However, You know, greater than 4 diopters, it has been shown that increases the risk of central staining. Higher levels correction greater than 4 can also increase the risk of a decentered lens in a treatment zone. So based on the International Myopia Institute guidelines, especially for children, the ideal candidates as far as refractive error are up to a -4 diopters. You can do more, but I'm just giving the recommendations that are ideal. And it's great that we have many, many options today for our children going through OrthoK as an option for them. So for Sammy, is OrthoK the best option? So if we look at his refractive error, is definitely higher than that 4. So maybe not. He's not an athlete, so it's not a big advantage for him to use OrthoK. Doesn't have allergies, he doesn't have a significantly large pupil, and as far as his ECL posture, the OrthoK is not really going to help with that. So for him, I decided not to proceed with OrthoK.